Good morning, ladies and gentlemen. Today, we are very happy to chair this session, the Era of Personalized IVF International Art Forum. The first session will cover the importance of PGT-A follow-up test. As a fertility physician, we every day try to do the precision medicine, try to select or prioritize the quality embryo for transfer. I think the PGT-A or the technology is already evolving for many years. It starts from the fish array CGH, followed by NGS technology. And the quality of the embryo is key for implantation. So how to select the quality embryo for further frozen embryo transfer is a task for our daily practice, especially for I&E physician. However, the embryo, they have many different phases. For example, they have some segmental or some lower-level mosaicism or higher-level mosaicism, or even the frank aneuploidy. So how to select the best embryo is a very essential task for our daily practice. And again, the biopsy per se, we still don't know the long-term effect. So the routine prenatal screen in conjunction with future amniocentesis by the SNP array to identify some of the UPD, uniparental disomy, also very important. Of course, the advantage of the PGT-A, they can diminish or reduce the rate of miscarriage, and also we can avoid some microdeletion, microduplication, de novo variants, etc. But still, this technology is not perfect because nowadays people try to use non-invasive methods, such as use cell-free DNA to identify to the good euploid embryo. But still, there are some shortcomings. For example, the false negative rate or some false positive rate because they only detection the placenta trifectatum, not the fetal. And also, this technology cannot identify the mosaicism. So today, we invite 4 robust and outstanding international speakers to share their knowledge with all of you. I hope all of you can enjoy the meetings. It is my pleasure to introduce Professor Raman Subramaniam. He is now the consultant obstetrician and gynecologist. He now serves at the Fetal Medicine and Gynecology Center at Pondering Hospital, Malaysia. He used to be the president of Malaysia Society of OB/GYN and also an honorary member of Royal College of Physicians as well as Royal College of OB/GYN. Today, he would like to touch upon the topic PGT-A, its limitations and follow-up testing recommendations. Please, Professor Raman, time is yours.
Good day, ladies and gentlemen. Welcome to this International ART Forum, the Era of Personalized IVF. And today I will be discussing the importance of PGT-A follow-up testing. If you look at the era of genetic screening, we are now having so many applications. You have carrier screening, we have pre-implantation genetic testing, we have prenatal applications, and newborn screening, and of course, postnatal applications. So today we will be concentrating on pre-implantation genetic testing and what happens during the prenatal period. I'd like to start off with discussing a case of a 37-year-old Parawan who underwent IVF and ICSI. All the embryos were good quality. She had a PGT-A done, which was told to be normal. And now at 12 weeks, was found to have an abnormally thick nuchal of 4.3 cm. And this is the image of the baby. You can see the tip of the nose, the skin, a very small nasal bone, and you see this large swelling around the neck going down to the abdomen. And this is the normal fetus, what it looks like. You can see the fingers here, the tip of the nose, the outside of the skin, the nasal bone, palate. Then you can see the brain, parts of the brain, and the cisterna magna, and you see a normal thin nuchal. Look at this in comparison to this very large fluid-filled space. So then the questions by the patient. What does it mean? Why did it happen? I was told that PGT-A is accurate. Still this happened. Why? Will my baby be normal? These are very valid questions for a couple who have undergone IVF, ICSI, and spent a lot of money to be told something may not be right with this baby. So this is just a very nice flow chart which looks at the type of gestation, single gestation versus multiple gestations. And you find that, you know, single gestation, NIPT, or your multiple gestations, ultrasound scan. If the structure is abnormal, then you do karyotyping or diagnostic tests, chromosomally abnormal, and of course, you may require a SNP microarray as a diagnostic test. So if the NIPT is a positive test, you will do this. If there is no call result, low fetal fraction, you will also do karyotyping. Nowadays, I just don't do karyotyping in most instances. I move straight into SNP microarray. And of course, when the results come out, you get a comprehensive genetic counseling. So this is useful because it's helping patients decide what are the best tests for their own situations, the right test, the right time, and the right patient. So in this particular case, when you have a thickened nuchal translucency, these are the possibilities. You can get chromosomal abnormalities in about 15%. You can have normal babies with transient thickening, although in this case, this is pretty large. Some, usually they're below 3.5, they tend to be okay. If nothing else is found chromosomally, it can lead to perinatal death. And of course, it can lead to structural abnormality. Nearly 50% of them are structurally abnormal, congenital heart disease, skeletal abnormalities, various genetic syndromes, hydrops and others. And some of these are actually thalassemia as well. So if you look at this slide, the relationship between nuchal translucency thickness and prevalence of chromosomal defect, miscarriage or fetal death, and major fetal abnormalities. And here you have the nuchal translucency and the various percentile. And this is the line of a priori, and then all the various 2.5 millimeters, 3, 3.55. Ours is just below this. And you find that with maternal age, you can get this. And of course, you have the risks associated with this. So you find that chromosomal defects, depending on which percentile they are, they tend to rise. The thicker the nuchal, they are much higher. The conditions associated with increased nuchal translucency are so many. I'm not going to go through all this. You can look it up in the journals, from cardiac defects, diaphragmatic hernia, and so on. And there's a whole lot of syndromes which are associated with increased nuchal translucency. So there comes to the cleavage stage embryo, and there is a lot of chromosomal instability during this period. And you have in green the normal, then you have the various like trisomy 7, UPD in 15, and monosomies, deletion. And I like this title, Chaos in the Embryo. So the embryo can be very chaotic, and it can give rise to a lot of issues during the cleavage stage. So there are 3 types of pre-implantation genetics, just for those who are not familiar with it. PGT-A is formerly known as PGS, and it looks for extra missing chromosomes, mainly for aneuploidy, right? Extra or missing chromosomes. And it cannot detect single gene disorders or birth defects like congenital heart disease, cleft lip and palate, and spina bifida. And the A stands for aneuploidy. Euploid is embryos that have the correct number of chromosomes. The other one is PGT-M, which used to be called PGT, and this is for inherited conditions and disease caused by mutation of single gene, for example, cystic fibrosis, or even like Fragile X and so on. It's only offered to those with an increased chance of passing on a specific inherited condition. The last one, more recent one, is PGT-SR, structural rearrangement, such as translocation or inversion, and that puts them at increased risk of creating embryos with unbalanced chromosomal issues. Today, since we are only looking at PGT-A, but the benefits of PGT is it increases the implantation rate, increases the chances of having a healthy baby, decreases the risk of miscarriage, because a lot of miscarriage is from aneuploidy and other disorders, reduction in multiple birth, and it can be combined with elective single embryo transfer. So one single embryo is transferred instead of 2 or 3 or more. But there are limitations to PGT-A. There's potential for false positive, false negatives, inconclusive results. And the reason for this, the biological challenges are mosaicism, which is, I'll talk briefly soon, self-rescue or self-correction, mitotic error during or occurring after timing of biopsy and testing, and biopsy challenges, whether we are taking the tophoectoderm, or inner cell mass. And this is the reason why you get all these either false positive, false negative, or inclusive results. So PGT-A by itself is flawed in some cases, not in all. And when you have mosaic, you get all the varieties here. And depending on where you biopsy, that's where the result can be. So when you look at chromosomal mosaicism, the fetal-placental unit, you can get either true mosaicism or confined placental mosaicism. So when you have confined placental mosaicism, may not affect the fetus, but we need follow-up diagnostic testing. Is amniocentesis preferred over chorionic villus sampling? I would personally do amniocentesis because the incidence, even with CVS, you may pick up mosaics, which you are not sure about. Fetal mosaicism may not be detectable by cfDNA. That's why identification of mosaicism may be less effective because of the contribution from the abnormal is very little, partial. So you may not pick it up, especially when you do fetal DNA. Maternal mosaicism is the other thing that can happen. Sometimes the mother is a mosaic. And when you do sequencing the Buffy code, they can determine that the maternal chromosome abnormality is confounding the result. So this is a mosaic, which is true both baby and placenta. Here is placenta only, here is baby only. So different kinds of mosaic. And if you look at chorionic villus, these are aneuploid and these are diploid. And you look at the cytotrophoblast and you look at the mesodermal stem, and you will find the core, and you find that it can be in the cytoblast or in the mesenchyme or both. So this is more like a true mosaic. So this is the unsolvable biological puzzle of mosaicism, and that's why it represents an insurmountable biological limit to PGT-A. And unless all cells in the embryo are euploid or aneuploid, the diagnostic error is possible. So this is a total mosaic. You usually will get an accurate diagnosis. When you get an ICM, intracellular mass, you usually may get, when you say euploid is a misdiagnosis. It's a trophoectoderm mosaic. If its mosaic is accurate, if it's euploid, it's misdiagnosis, aneuploid is misdiagnosis, and so on. So a lot of misdiagnosis is possible. And this is some recommendations from various newsletters from international conferences. This 2019 that PGT-A cannot be 100% accurate due to technical and biological factors. You need a parent-informed consent, euploid embryo preferred for transfer, and for considering transfer embryo, which is mosaic, need to discuss further IVF or PGT-A cycles, whether the level of mosaicism is low, and prenatal diagnosis is highly recommended. So again, for mosaic embryos, low-level mosaicism is preferred, and mosaic percentage possibly a better predictor than specific chromosome number. And consider the specific chromosome number. It can be associated with uniparental disomy, IUGR, life-born syndromes may be given low priority. So here's an article from the New England Journal in 2015, where they actually transferred high levels of mosaics and actually had healthy babies at birth. So this is a revolutionary paper that not necessarily when you transfer them, because of trisomic rescue and others in the fetus where they push to the placenta, you may actually have healthy babies. So not all of it is bad. So now we go back to this case scenario, what to do? Offer CVS or amnio? Do we offer microarray? Well, the risk for CVS, if you look at the current literature, is about 0.75 to 1%, while it's 0.25 to 0.5% risk for amniocentesis. But in this case, I would offer a CVS and a microarray because this is certainly quite advanced in the pregnancy, and I need to get a decision whether I should carry on. And so I would do this. But if it is a bit more advanced, I would, or if it was a mosaic, then I would actually do an amniocentesis, which is better because there's less chance of getting a mosaic, which you can't interpret with CVS. And if you get this kind of results with CVS, you still have to do an amnio around 15 weeks and above. So what PGT-A follow-up test should be considered? There are patients, because of associated risk of miscarriage, decline diagnostic testing, and choose prenatal screening, first trimester and second trimester serological testing, nuchal translucency screening, or pre-fetal DNA, right? If the chromosome or chromosomal segment of interest is in fact able to be assessed by NIPT, use an aneuploidy can be detected. It is important to recognize that NIPT is not designed for detection of mosaicism and may give false negative results. False positive results may occur because NIPT analyzes placental and not fetal DNA. And I like to add that sometimes maternal mosaicism and maternal cancer causes weird chromosomes as well in NIPT. Prenatal diagnostic test is performed. An additional analysis on prenatal samples should be considered depending on the specific PGT-A result. Chromosomal microarray, a partial chromosomal aneuploidy is involved. Uniparental disomy studies depending on the chromosomal involved, and additional cell counts with a traditional karyotype in an effort to identify low-level mosaicism. So all this has been recommended by the American College of ONG, and it's a good thing to follow. So non-invasive NIPT, most of you know that it is actually, the source is mother and placental, not fetal DNA. And placental DNA is not fetal DNA. So the results maternal and placental genetic makeup, and placental genetic makeup not always the same as the fetus. Again, we have gone into NIPT usage, and to replace traditional serum screening with NIPT because positive predictive value is higher, and those with a family history 11, 13, 21 chromosome trisomy, yes, and patient concerns with invasive tests. But in the end, if the NIPT is positive, a diagnostic test should be done. But it's not recommended to use NIPT to detect aneuploidy other than 13, 18, and 21. Patients with multiple gestations is very difficult. It's much, much more complicated depending on the fetal fraction of each. And when a fetal structural anomaly is identified, definitely NIPT shouldn't be done. You should do a diagnostic test, and it could be a CVS or an amniotic. And of course, SNP array detects abnormalities that are undetectable in cell-free DNA. And if you look at NIPT, 66% undetectable, 34% detectable. And under the NIPT are all the, the aneuploidies, plus the sex chromosomal abnormalities and some of the microdeletions. But a lot of them, like mosaic turners and other microdeletions, microduplications, pathogenic, likely pathogenic, likely benign, and uniparental disomy are not detectable. So when you do SNP, you can detect chromosomal copy number variation in high resolution, and you can detect loss of heterozygosity, uniparental diatomy, triploidy, and mosaicism. So it's a far, far better test. Thank you very much for listening. I look forward to getting your questions. Thank you.
My privilege to introduce Dr. Chang. Dr. Chang is now the president of Fertility Society of Republic of China. He used to be the director of maternity and gynecology department and Jiayi Christian Hospital. Later on, he served as the director of the Human Reproductive Center at the China Medical University, Taichung, Taiwan. Today, he would like to touch upon the topic, how to use the clinical aspect in optimization of healthy IVF live births, especially from correct follicular genesis to PGT-A and SNP array prenatal testing. Now, time is yours, Dr. Chang.
Good morning, everybody. Thank you, Professor Chen. Good morning, everybody. This is hello from Taiwan. Today, I'm going to talk about the clinical aspects, how to improve the oocyte quality and the embryo quality. We know PGT-A can let us to choose a good embryo, euploid embryo to transfer, but it knows everything. But sometimes it's too late to know, because sometimes we found that we have no embryo can transfer. This is why we are facing more and more challenging, difficult, aged patients, and these patients provide less amount of oocytes and also the poor quality oocytes. Now we mostly use Poseidon group to divide them, and difficult cases like Poseidon group 3 and 4, less than 35 years old, AFC less than 5, or older than 35 years old and AFC less than 5. Today we are going to share some of our experience on. The first case came to me is 2 years ago at the age of 38. That she's married for 11 years. She tried 3 times IVF at the clinic, but she got altogether 4 times missed abortion. Even after the PGS plus FET with euploid embryo, also aborted. Even natural conception also resulted in missed abortion. And later she was found with maternal chromosome 9 inversion. Her period is irregular, MH is low, 0.8. The aborters found 46XX with chromosome 9 inversion. I really doubt maybe they got the maternal tissue, not the fetus tissue. The immune study was told normal. Next slide. Now this is a chromosome study. we can see inversion 9. Next slide. And on initial examination, we found no myoma. The CD synthesis is free. A little bit, few follicles, not many, and but the growth is 2 days earlier. So first of all, I give her 5 months DHA supplement. We did the OPU once, we got 3 oocytes. Then OPU again in 2 months, we got another 6 oocytes. Altogether, fresh and thawed oocytes will go for fertilization. Finally, we got 1 day 5 and 1 day 6 blastocyst for PGS. Later, we found that the day 6 3 cc blastocyst is a mosaic, and the day 5 3 BBBT is abnormal, aneuploidy. So obviously, the embryo quality is no good. I suggest another try. So I let the husband to take property. So we did OPU again in 4 months, and we got 4 oocytes for freezing. The next month we did again, we got 7 oocytes, 5 mature for freezing. Then another OPU. The next month we got 6 oocytes for freezing too. Finally, we got a 12 thawed oocytes for fertilization, and we got a 2 day 5 blastocyst for PGS. Obviously, the oocyte quality is improved, and we got 1 euploid day 5 blastocyst. And we transferred this one and the previous mosaic one, and we got a singleton. Altogether, 18 months treatment. This is the PGT-A results. Obviously, from the amniocentesis SNP array test, we can tell the euploid embryo implanted. Okay, this is the blastocyst we transfer. Next one. The case 2, when she came to me 4 years ago at the age of 43, now she's 47. At that time, she married 1 year, primary infertility, short cycle already, 25 to 26 days. MH is low, 0.79. But the ultrasound scan found the follicle growth is normal. So since the follicular growth is normal, I pick up the egg for her at the age at 44. We got 3 mature eggs for freezing. Then the next month we tried again. We got 1 more oocyte. The 1 fresh and 3 thawed oocyte for fertilization. We got 3 days 3 embryo, but only 1 has top grade. Then for the rest of the treatment, I let her take DHA. And luckily, the process is not smooth. Either ovulate before OPU, either no egg to pick. Then finally, we pick up the chance. We did the double trigger, and OPU got 2 oocytes for freezing. Then she disappeared. Maybe she's just too disappointed. And came back with family in 6 months, and we tried to pick more eggs, but I watched for 2 months and found that there is no egg at all. And finally, we thawed all the oocytes for fertilization, and we got 1 more day 3 embryo. And altogether, 4 day 3 embryos we transfer back in a frozen cycle, and got a singleton. And she just delivered this year, July, at the age of 47. This is the embryo we transfer. But during amniocentesis, the karyotyping is all normal, but the SNP array prenatal test found out 533 kb the triplication. This is scary because she's aged, and 1 very short period region does include 3 omnin genes. Then we try to check more. Finally, we found that this is inherited from the father, and ultrasound check found the baby is normal. So finally, the couple decide to deliver this baby. The next case is very old. When she came to me at 5 years old, she's 43 years old. Now she's 48. Married 15 years, delivered 2, 12 years ago, and tried to conceive for 3 to 4 months only. Regular period, but from ultrasound scan, I can tell that the ovary is stimulated, and we can find 2 dominant follicles. This is abnormal. Next one. And then I gave her 3 months DHA. We did OPU and got 5 oocytes for freezing at the age of 44. Then another 4 months DHA we pick up and got 5 oocytes, all go for freezing. Then she also disappeared. Then came back in 2 years at the age of 46 because she moved to Taipei, not live in my town. At that time, we tried to pick up more eggs, but obviously the ovarian function is poor. She can only get 2 oocytes for freezing, and another month, another 4 oocytes for freezing. Next slide. Since the husband also aged and the semen quality is no good, only found a 1% normal morphology. So I let him take drug. And after the husband finished treatment, we saw all 16 oocytes for fertilization. Finally, we got 5-day 5 blastocysts for freezing again. And for sowing cycle, we saw the 2 blastocysts and the transfer got a singleton. And she's going to deliver in 2 months, 2 weeks. This is the blastocyst. Next one. And since she moved to other hospital, she did with the amniocentesis, found that the baby is all normal. It's normal baby girl. And the last case we share is 33 years old. When she came to me 2 years ago, she pregnant before being aborted. Short cycle already, 25 days. The MH is shockingly low, 0.04. At the time, she was taking Chinese medicine. Ultrasound can see 2 follicles bilaterally. But the husband is not with her. He's working in Bangladesh. And then, but after she suspended the Chinese medicine, come back, I can't find any follicles. So I let her take the DHA for 5 months. Then we did OPU and got 1 oocyte for freezing. The next month, tried again, got 2 more oocytes. So when the husband come back in 3 months for Chinese New Year holidays, we try to pick more eggs, but that time we got no eggs. So the husband froze the semen and then left the country. Then 2 months later, we tried the OPU again, and we got 4 oocytes, all for freezing. So finally, we saw all the 7 oocytes and the semen for fertilization. And luckily, we got 2-day 5 and 1-day 6 blastocysts for cryopreservation again. For FET cycle, I saw all 3 blastocysts and transfer, and she got a twin pregnancy. This is all the 3 blastocysts to transfer. From morphology, only 1 is good. So unfortunately, the amniocentesis found that it's a baby girl and a baby boy. But the boy found the balanced translocation. We checked the parents. The husband have to test in India, but the parents karyotyping all normal. Obviously, this balanced translocation is de novo. So since the ultrasound scanning found the babies are all normal, the couple decide to deliver these 2 babies in the future. This is the array. So we can tell array didn't find anything wrong. Okay, and since the time is limited, I want to conclude all these experience. And obviously, we did the PGT-A let us to pick up, let us to transfer the euploid embryos, but the nature of the embryo will never be changed with this procedure. That's why I said when we know the nature of the embryo, sometimes it's too late because it's aneuploid. For Poseidon patients, for low prognosis patients, poor ovarian reserve affects ovarian oocyte quality than the embryo quality. To improve the oocyte quality, sequential continuous multiple OPU is necessary to let them have high quality oocytes. And oocyte, for our experience, oocyte cryopreservation has been proved efficient to save enough oocyte for low prognosis patients. The DHA, mostly I found that they have positive effects to improve the oocyte number and the oocyte quality. But someone, the case 2, obviously is no good. So it's still controversial, still need to individualize to set for the patients. That's all I want to say. Thank you.
Now, I would like to introduce Dr. Michael Richardson. He obtained his PhD degree in human genetics from University of London in 1996. Later on, he moved to Thermo Fisher as a leader in clinical application specialist at the Thermo Fisher Scientific in 1913. Also, he in charge the business development at the same company. Right now, he is in charge of reproductive health, the same company in Singapore. Today, we'd like to talk the topic entitled The Use of Chromosomal Microarray for Prenatal Testing After IVF. So please, Dr. Richardson.
Thank you very much for the introduction. In this talk, I'm going to discuss the importance of using chromosomal microarrays in prenatal testing following the transfer of an IVF embryo that has undergone pre-implantation genetic testing. Currently, I'm employed by Thermo Fisher Scientific, and I am the Reproductive Health Business Development Manager for Asia Pacific and Japan. Throughout this talk, I will be referencing products from Thermo Fisher, and these products are for research use only. I thought I'd start by giving you an overview of pre-implantation genetic testing. And in this process, we're usually taking a biopsy from a blastocyst, so a day 5, day 6 embryo, and you take a few cells from the trophectoderm. These cells are then undergoing whole genome amplification, and then the samples are put through the sequencing platforms before going into data analysis. Now, this workflow is from the iron reproductive PGS assay, and it's a very simple and rapid assay that gives you data in less than 1 day. It's also very flexible in the number of samples that you can run and provides very accurate and automated mosaic level calling. Here is just an example of the data output, and you can see this is very visual and easy to interpret. And in the top data trace, we have the chromosomes on the x-axis, we have ploidy status on the y-axis, and you can see here we have a trisomy 18, and this is indicated in a summary table. You can also use workflows to mask gender, so you will still get information whether there's an abnormality, but you won't get any information around gender of that particular embryo. And you can use it to detect those segmental abnormalities, and here this was a 21 megabase gain. And you can get more information from a detailed view that gives information around cytoband location, size of the abnormality, as well as some QC metrics to give you a good indication of data quality. Now, mosaics and transfer of mosaic embryos has been generating a lot of interest lately. And in this particular study from the Center for Reproductive Medicine at Weill Cornell Medical College, they created some artificial mosaic samples using a euploid male sample and a trisomy 21 female sample. And they created mosaics at these different levels from 0 up to 100%. Here I'm just showing you some of those data plots from the full trisomy through to the full euploid. And then in between, we have these different levels of mosaics that's been detected and called by the software. In this particular study, they achieved a very high positive predictive value, but there were there were 3 false negatives, and these were in the sex chromosomes at very low level mosaicisms at the 20% mosaic level. Here, this is just a depiction of the development of an embryo. And as you can see, we go from the 2-cell stage through to the blastocyst stage, which is where we are generally taking a trophectoderm biopsy. And when you take the trophectoderm biopsy, these trophectoderm cells will go on to constitute the placenta. The inner cell mass will go on to constitute the embryo or the fetus. So when we're taking a trophectoderm biopsy at blastocyst stage, we're using the results generated to really infer the chromosomal makeup of the inner cell mass. Now, while the trophectoderm biopsy does provide a very accurate assessment of the inner cell mass, there is the potential for error. Here, I've just tried to give an example of some of the situations that may occur when you're doing pre-implantation genetic testing. And I'm not going to go through every single one of these, but if we look at where we've got either a complete euploid embryo or a complete aneuploid embryo, you're going to get a pretty good call. But when you've got mosaics involved, this is when you have the potential for some false negatives or false positives, depending on the number of cells you take, the location of the cells that you're taking them from. And this can lead to some false negatives and some false positives. So as I mentioned, the trophectoderm biopsy is really an indirect method that's used to predict the chromosomal makeup of the inner cell mass. Very similar to the way NIPT is used as an indirect method to predict the chromosomal makeup of a fetus. And we do know that the trophectoderm biopsy does provide a very accurate measure or a very accurate assessment of the chromosomal makeup of the inner cell mass. However, there is the possibility for false positives and false negatives. And I've just highlighted two studies to illustrate this effect. And in the first one by Chang et al. From 2018, they used a study on 29 embryos where they compared a trophectoderm biopsy to an inner cell mass biopsy. And here they had 9 samples that were euploid from their TE biopsy. But when they biopsied the inner cell mass, they found one of those was a mosaic at 40%. The other 8 were euploid. But when they biopsied those samples that were mosaic at the trophectoderm, they found 8 of them were mosaic, and these mosaics differed in both the level of mosaicism as well as the chromosomes that were involved. Okay. In another study by Takahashi published earlier this year, again, they studied 29 embryos, but in this case, they compared the trophectoderm biopsy to a whole blastocyst. And here they had 12 euploid trophectoderm biopsies, but when they ran them against the whole blastocyst, they found one of them that was a complex mosaic. So this embryo had multiple different chromosomal abnormalities, as well as multiple different mosaic levels. And then when they took those mosaic TE biopsies, they again found the majority were in agreement, they were mosaic, but there was a difference in the chromosomes involved, as well as the level of mosaicism that was being detected. So when you are doing PGT-A, there are a number of limitations. And one of those is that you're really looking at chromosomal events greater than 10 megabases. With the iron tolerant reproseq, you can detect down to greater than 2 megabases with some special workflows. Your mosaicism in the trophectoderm is limited to greater than 20%. You will not detect polyploidies. You can detect some polyploidies if there's an involvement in the sex chromosome, such as 69XXY. You will get an indication that there may be polyploidy involved. Uniparental disomy, loss of heterozygosity, 2 other very important aspects that you need to detect, but you're not going to pick those up with pre-implantation genetic testing because this requires a really genome-wide SNP analysis. You also will not pick up any conditions where there are balanced or structural rearrangements that do not result in any gain or loss of genetic information. So that brings us into prenatal testing. And why are we going to use chromosomal microarray? You could use karyotyping, but with karyotyping, we know this has a very low diagnostic yield. It's also very slow to get results. You need to do cell culture to generate enough cells to do your karyotyping, and this takes time. You can also get culture failure, so you may not be able to generate data for all of those samples. The resolution is above 5 megabases, and it does require specially trained individuals and can be very subjective. Whereas if we're using a chromosomal microarray, we know that this has a much higher diagnostic yield. It's much faster. You don't have to do cell culture, so you can get the data out to the patients that much faster, just a couple of days. You get much higher levels of resolution. So you're looking at abnormalities from anything from 10 kilobases up to 2 megabases. It really depends on the resolution of the array that you're using. And because it's interpreted by the software, makes the results that much more consistent and reproducible. So here is just an example of different types of array, and these are the applied biosystems cytoscan arrays. At the lowest resolution level, we have the Cytoscan Optima. This will give us detection between 1 to 2 megabases and absence of heterozygosity around 5 megabases. There are some special cases where you can get down to 100 kb levels of resolution. The 750K array has 750,000 probes. It's a combination of both copy number and SNP probes. So we can look at absence of heterozygosity greater than 5 megabases, mosaics greater than 15%, but we're getting resolution to 400 kb levels. And then we move to the HD array, which has 2.6 million probes, gives us much higher levels of resolution down to 10 kb, and your absence of heterozygosity greater than 1 megabase. Okay. So there's just different types of arrays for different scenarios that you may use. In prenatal testing, we're generally using the 750K array. So if anyone's not familiar with how a digital karyotype looks, I'm just illustrating that here on the right-hand side of this chart. On the left-hand side would be a traditional karyotype where you're visually inspecting and looking for the abnormalities, whereas in a digital karyotype, the software is making those calls for you and giving you indications of where there may be a loss in red or a gain in blue. So it makes it very easy to interpret this data. The cytoscan arrays from Applied Biosystems are all a combination of SNP and copy number arrays. And it's very important to have SNPs on a microarray because this provides additional levels of analysis. One of the most important things is it allows you to do your loss of heterozygosity. It also enables you to do or to detect any contamination. So you may be picking up maternal cell contamination. It gives much better accuracy around mosaic event calling and allows some parent of origin studies. If you want to trace back information or where an abnormality came from, you're able to do that with the presence of these SNPs. Having both copy number and SNP probes allows a much more balanced spacing of probes across the whole genome. So you can get a much better accuracy level in determining the breakpoints or the location of various breakpoints. So here is just an example of how the data from a microarray would look. Again, here we have the digital karyotype at the top, and we can see there's a red and a blue bar in chromosome 7. So we can zoom into chromosome 7. And again, here you can see the blue bar indicating a gain. And here we have a red bar indicating a loss. Looking at the loss, you can see we have a shift away from the midline with our copy number probes. And then if we look at the SNP probes, you can see we're going from 3 lines of SNPs to 2 lines of SNPs. So again, this is giving us very good indication that we have a loss of or a copy number loss at this particular location. This is an example of a 35% mosaic on chromosome 13 and a 2.8 megabase segment. In here, it's very difficult to see the abnormality just in the copy number probes. But if we're looking at the SNP probes, we can see we've gone from these 3 copies or these 3 rows of SNPs into 4 rows of SNPs. So this gives us an indication that we've got a mosaic loss occurring at this particular location. Here is an example of a loss of heterozygosity or a long contiguous stretch of homozygosity. So here we have an actual loss. So this is shown in the copy number probes as well as our SNP probes. Again, we're going from 3 copies or 3 lines of SNPs to these 2 lines of SNPs. However, here we have no change in copy number, but we do change the number or the number of rows of SNPs. So if we just use copy number probes, we wouldn't be able to detect that we've got a long contiguous stretch of homozygosity. So we need to have those SNPs to be able to determine this abnormality. And finally, here is an example of a genome-wide long contiguous stretch of homozygosity. And you can see that we have all of these purple bars at multiple locations across the genome. And this is an indication that there may be some consanguinity in this particular sample. So in closing, I just thought I'd put up a table to give a quick comparison of chromosomal microarray in a prenatal setting versus your pre-implantation genetic testing. So both assays will detect chromosome copy number, and they will both detect segmental abnormalities greater than 10 megabases. However, pre-implantation genetic testing will not really detect things below 10 megabases without some special algorithms. Whereas with your chromosomal microarray, depending on the array and the resolution, you can go down to 10 kilobases, 400 kilobases, or 1 to 2 megabases. You don't really look at SNPs in pre-implantation genetic testing, so you're not detecting polyploidy, but you can detect those polyploidies with your chromosomal microarray. Both systems can detect mosaicism greater than 20%. You're not going to pick up loss of heterozygosity or uniparental disomy with pre-implantation genetic testing. Microarrays, when you're running on an invasive test, are giving you a direct indication of what's going on in the actual fetal genome. When we take TE biopsy, we use that data to infer the chromosomal makeup of the actual fetus or the inner cell mass. Neither system will detect those structural rearrangements if there's no loss or gain of genetic material. And with pre-implantation genetic testing, we're using whole genome amplification, whereas we don't do any whole genome amplification when we're running a chromosomal microarray. So I hope that gives you a very good indication of the importance of using chromosomal microarray in your prenatal follow-up after a transfer of an IVF embryo. And with that, I thank you all very much, and we can take any questions. So thank you all.
Now, we'd like to invite Anya Huang to talk about the genetic counseling for preconception and prenatal chromosome testing. Ms. Huang is board-certified genetic counselor from US and Taiwan, now work for PGT-A Corporation. She obtained a master's degree in genetic counseling from Case Western Reserve University, as well as the master's degree in genetic epidemiology, Washington University at St. Louis. So I'd like to invite Anya to share her experience in counseling.
Hello, everybody. Good morning. My name is Anya Huang. I'm a genetic counselor with PGT-A Corporation in Taiwan. Thanks to the organizers for having me as one of the speakers, and also thank you to the moderator, Dr. Zhen, for the nice introduction. Now, today, as a counselor that has worked on both sides of things, working clinically, seeing patients, talking to them about genetic testing, as well as working in the laboratory, overseeing genetic health testing, I wanted to share a few things with you that I feel is important by talking to patients about chromosomal genetic testing, whether prenatally or preconceptionally. So this is my full disclosure. So this is a picture that I took when I was vacationing in this beautiful island up of the east coast of Taiwan. The island is called Laihu, or Orchid Island. And it's very well known for its beautiful water where people actually go scuba diving and snorkeling. Now, in a perfect world, I will be sitting here right on the beach, watching the kids play, feeling the wind, feeling the waves, and maybe sipping on a glass of wine. However, it's not a perfect world, and I haven't won the lottery just yet, and I'm still here working. So in a perfect world, we will have one super perfect genetic test, which, with one test, we will get to know everything we need to know about growth and development, and it will be very simple and it will be very cheap. However, we are not in a perfect world. So we are faced every day with, how do we pick and choose the right test for our patient? Which one's better? Which one's correct? Which one gives us more answers? So it's really difficult, going through all the testing and knowing the right option for the patient. And I believe this can be done through counseling before and after testing. Once we get to know our patients, knowing why they want to do the testing, once we get to know the actual test, what's the risk, benefit, and limitation, and know the lab that you're working with, what's the testing item, what's the resolution and reporting criteria. Also, after testing, what does the test result actually mean for your patient, the patient's family, and the healthcare medical team? So overall, I think if we, this is done right, we are able to help the patient make an informed decision regarding, what's the right test for them. So today I kind of want to go over a little bit about embryonic aneuploidy testing and a little bit about fetal aneuploidy testing. Now, I think to today's audience, I really don't need to reiterate the benefit of PGT-A. Now, by looking at the chromosome copy numbers of the embryo biopsy, we're trying to find the one with the highest potential in giving us an increased implantation rate, a decreased miscarriage rate, and a decreased chance for fetal anomalies. However, we all know PGT-A is not perfect. With the way the test is designed and how the test is run, we can run into false positive and false negatives, and also inconclusive or mosaic results. And this is to no fault of anyone's. It's just kind of the different factors that come into play in terms of this whole test itself. It could be biological factors, sampling factors, also technical issues. So a lot of the questions I actually get today kind of surrounds the mosaic PGT-A results. I think the biggest question is, what do we do with these results? What do we do with these embryos? Do we transfer the embryo or not? How do I select the embryo? What's the order? Which chromosome is better? Which one's safer? There's still a lot of questions. It's still an ongoing debate. Really, there's a lot of discussion on this, but no kind of the true consensus on this. A couple medical societies came out with kind of recommendation and guidelines at the end of last year. And these kind of involves how do we care for IVF patients, especially if we already had PGT-A testing. The general consensus would be, always transfer euploid embryo first. This is the one you want to prioritize for transferring. If there's no euploid embryo, the patient should be offered the option of another IVF cycle. And the thought is more cycle, possibly more embryos, and possibly some euploid embryo. If these two options are not feasible, we can talk to the patient about transferring a mosaic embryo. However, the patient will need to know the increased risk for fetal anomalies or increased risk for miscarriages, and also, but there's a potential for a healthy pregnancy. However, the fetal outcome is unpredictable. We still don't have enough data or enough evidence to know what the kind of the long-term or longitudinal outcome would be. All in all, regardless of which embryo, what kind of PGT-A result the embryo has, prenatally chromosome testing is really, really important and should be strongly recommended to your patients. So this is a really nice table put together by a New Jersey group, and they kind of gathered together or collected papers out there that's describing mosaic embryo transfer. And of the close to 2,800 mosaic embryo transfer, the overall success rate is about 38%. However, of interest, there is actually this one case report of mosaic embryo transfer where the mosaicism persisted throughout the pregnancy into postnatally. So it started out with a 35% mosaicism on the PGT-A result, and prenatally they were still seeing the mosaicism. In postnatally, they are still seeing 2% mosaicism in the fetus. However, given this low percentage, the baby was actually born clinically normal and was normal in terms of growth and development at the time of the publication. So the importance of prenatal testing following a PGT-A was reinforced by ACOG, the American College of OBGYN. So they actually state patients who conceived after PGT-A should be offered aneuploidy screening and diagnosis during pregnancy. Now, prenatal testing for chromosome anomalies, there's two options. There's two general big categories, the screening test and the diagnostic test. So screening tests are your common, usually think about first trimester screen, cross-screen, sequential, integrated, and the cell-free fetal DNA testing. And generally, we're talking about getting blood draws or ultrasound surveys. And overall, the risk will give you kind of a calculation. What's the risk for this pregnancy? What's the likelihood? What's the chance for this particular pregnancy to have Down syndrome or other chromosome anomalies? However, it does not give you a yes or no answer. So these are screening tests. It can have both positives and both negatives. So anytime we have a high risk screening test result, we should always follow by a diagnostic testing for confirmation, because truly through diagnostic testing is the one we can actually know what the actual fetal status is. So today I want to focus a little bit more on the cell-free DNA testing. So since it's actually really, really popular in the IVF world, because I think a lot of patients feel like getting pregnant is so difficult. They don't want to take any risk, involved with invasive procedures. So they wanted to do something that's safer. And in terms of screening tests, as far as screening tests is considered, cell-free DNA is actually the most accurate maternal serum screening test to look for fetal aneuploidy. However, we do have to kind of realize and keep in the back of our minds the limitation surrounding the cell-free DNA testing. So with cell-free DNA testing, the actual free-form DNA we look at in the maternal blood actually comes from the mother and the placenta, not directly from the fetus. And that's really important to remember. The DNA we look at is not directly from the fetus. Now, cell-free DNA testing works because we're assuming two things. We're assuming the mother has normal chromosome makeup, and we're also assuming the placenta has the same genetic makeup as the fetus. However, we're not in a perfect world, so those two promises may not always hold true. And that's when we have false positive and false negatives. So cell-free DNA testing is just a screening test. Just to remember, anytime you have a high-risk result, you should always follow with the confirmatory testing through a diagnostic testing. A couple of other things with cell-free DNA testing is if you think about the free-form DNA, the origin is from the placenta, and it's really truly the placenta originated from the trophectoderm cells that we see at the biopsy. So we're pretty much testing the same thing. And the way the cell-free DNA testing is designed is actually not designed to look at mosaicism. So it does have a low sensitivity and low specificity in detecting mosaicism. And also not all chromosomes are the same. We know cell-free DNA is really good in looking at chromosome 13, 18, and 21. However, when it comes to other chromosomes or segmental small deletion duplications, it's not as accurate and has a higher false positive and false negative surrounding these other conditions. So diagnostic testing will be important in this kind of situation. Now with diagnostic testing, it's usually done through a procedure like amniocentesis or CVS, where we actually get a little piece of the placenta tissue, a little piece of the tissue from the pregnancy to look at the actual chromosome status of the pregnancy. And this can be done through chromosome analysis, such as karyotype, microarray analysis, or sometimes FISH analysis. With amnio CVS, it does give us more of a definitive diagnostic yes or no result, but the trade-off is there may be a small risk involved with the procedure itself. So a lot of patients may be a little bit more hesitant going through these procedures just because of this risk. However, with the amnio or CVS, we are able to get more results or test for more conditions compared to other screening tests alone. So commonly in pregnancy, we think about Down syndrome, trisomy 18, trisomy 13. And these are well known because we know the incidence of these conditions actually increases with maternal age. However, there are other kind of more rare chromosome conditions, such as small microdeletions, microduplications, which are not related with maternal or paternal age, and they can occur or happen to anybody, and the risk is all the same. And because of these small size of the genetic changes, they are typically very difficult or hard to detect through PGT-A, cell-free DNA testing, or karyotype. So instead, however, microarray is something that can detect these small genetic changes. So microarray does give you a more comprehensive overview of the genetic or the chromosome status of the fetus. So things to kind of think about when you do prenatal diagnosis as a follow-up to PGT-A. The first thing will be the specimen you're getting. So between amniocentesis and CVS, amniocentesis does give us a more direct analysis of the fetal cells. So we're gonna be able to know the fetal status more directly compared to CVS where we're actually testing the placenta. Again, placenta comes from the trophectoderm, so similar to what we're looking at with PGT-A. Another thing is ASRM does suggest maybe think about additional testing or a test analysis depending on the specific PGT-A result of the embryo that got transferred. So think about microarray, especially if the embryo that got transferred has a PGT-A result suggesting mosaicism for segmental chromosomal aneuploidy. And also just think about microarray in general, because with microarray, we're able to pick up microdeletions, microduplications, which by default will be missed by PGT-A and karyotype just because of the resolution limitation. When we're talking about mosaicism, maybe talk to the cytogenetics lab that you work with and ask them to look at more cells to rule out low-level mosaicism. And also think about uniparental disomy, so your UPD disorders, especially if the embryo that got transferred have a PGT-A result suggesting mosaicism with one of these specific chromosomes. So a couple words about UPD disorder. So I think this may be familiar to most of you. So uniparental disomy is where you have two chromosomes from the same pair. So instead of inheriting one chromosome from each parent, both of these chromosomes come from the same single parent. Now, uniparental disomy, if it happens to these 6 specific chromosomes, it can lead to clinical abnormalities and more severe clinical symptoms. And the most famous one is probably your UPD-15, which is associated with Prader-Willi syndrome and Angelman syndrome. The reason we have to think about UPD is theoretically, UPD occurs when you have trisomy rescue and or monosomy rescue. And this is the same mechanism that we think could partially explain why a mosaic embryo will lead to a healthy pregnancy, and in the end, we won't only see normal cells in the fetus of the baby. It's because of self-rescuing. So because of the mechanism is similar, so we feel like, theoretically there may be this risk for UPD disorder. However, UPD is not detectable on karyotype and PGT-A. So when you want to do UPD testing, you kind of have to think about this other molecular testing methodologies such as STR or methylation analysis or microarray with SNP probes. So kind of to wrap up, I hope I have drilled in you that PGT-A is not perfect. It doesn't test for all possible genetic conditions. And prenatal testing, whether screening or diagnostic, prenatal testing should really be something that's as a supplement to PGT-A in your overall care for your patient. And between screening and diagnostic testing, which one's better? This really, one is not necessarily better than the other. Really depends on what the patient will want, what risk they're willing to take, and what's the situation with the actual embryo itself, what's the PGT-A result. So all these should be considered when you talk to your patient about genetic testing. And just as we kind of discussed previously, one size does not fit all. Every patient have every need, every situation is different. So talking to your patient pre and post test counseling does give you kind of an overview and understanding how to personalize your patient's care. So with that, I'd like to thank you for your attention. I'm happy to take any questions or comments regarding this talk. Thank you.
Thank you for the brilliant sharing. We come now to our first panel discussion. Regarding the topic, we have select some questions raised by the participants, and we'll let the moderator and speakers have an in-depth discussion. Okay, I think all the speakers are all on board, and Dr. Jen will moderate this. Please, Dr. Jen, the time is yours.
Thank you for the 4 outstanding speakers talking about the importance in PGT-A. Now we come to the panel discussion session. First, a question. According to the guideline, when there was no euploid embryos to transfer, low-level mosaic embryo could be considered. If so, how to define the cutoff value of low-level mosaicism? Would mosaic result as low as 20 to 30% be reliable in PGT-A testing? I think this question goes to Michael and Anya, please.
Okay, thanks. I can address the part about the mosaic testing and 20 to 30% level of testing. And with today's pre-implantation genetic analysis, or the analysis platforms, especially the NGS-based platforms, they're given a very sensitive level of detection at your mosaicism greater than 20%. This has been shown in, there's multiple different studies out there. There's a lot of publications to show that this level is in good concordance to what is being expected from basically either mixture of cell lines or artificial mixtures with genomic DNA. With the platforms, you do have the possibility to change some of those settings to give you an increased confidence in the call. You're able to change some sensitivity settings. You're able to use confidence and QC metrics to give you a lot more confidence in the calls that you're getting. So a lot of the studies that have been done have been using these artificial mixtures. But when you're coming to doing an actual biopsy and using that biopsy material, this is really just obtained from a few cells. And there is the possibility for a lot of variability. You've got the number of cells that you're taking, the quality of those cells, the quality of that biopsy that you've taken. And in addition to that, you've got, what is the mosaicism across the whole embryo? Remember, when we take a biopsy, we're taking just a few cells, maybe 3, 4, up to 10 cells. And we use that information to make an inference across the whole embryo. But what you will define within your cells, if you pick up that 20%, it's a pretty accurate measure of what you're getting in there. Okay. So I think I'll pass on the next part of this question over to Anya, and she can maybe address some of the guidelines.
Sure, I'll try to tackle the first question. I think it's a very good question. Based on the literature and our own internal lab data, we define low-level mosaicism as anywhere between 20 to 50%. I believe some lab uses 20 to 40%. So across the guideline, I think they're stating anywhere below 40 or below 50 will be where you define your low-level mosaicism. And I kind of want to echo Michael's comment a little bit that, with the platform, we know based on, literature, based on internal validation study, we know we can detect true 20% or 30% low-level mosaicism. But in real life, there's so many different factors that can play into reading the data analytically. Is the DNA quality good or poor? It all may affect how you read the final data. But I think we need to look at the bigger picture, whether the level is 20, 25, 30, or 40, 60%. really the specific number may not be the biggest concern, but more importantly, once we transfer these embryo, prenatal testing should really be followed just to check, how the mosaic is play out later in the growing fetus. So really the follow-up will be more important than focusing on, what the specific number is, because what we really want to know is the final growing fetus.
Thank you. I think from New England Journal of Medicine a couple of years ago, they also published 18 cases. I think the mosaic rate are almost up to 50%, but I think 30% of the group also conceive and have labor. So I think this is a priority issue. If you do not have a good quality or you produce the embryo, the low mosaicism will be to consider for transfer. Then I would like to ask the second question. If patients take non-invasive prenatal testing, NIPT as their first choice, any precautions or clinical management suggestions for those patients? I think this question should go to Dr. Raman or Dr. Chang.
Perhaps I'll go. Sorry, you go ahead. Dr. Chang.
No, you first.
Okay.
You're first, please. You're first.
I presume that this is related to PGT-A being done because, not all of them have PGT-A and some, come without PGT-A. In those who haven't had PGT-A, then we will do a detailed scan at about 13 weeks, and then they can decide whether they can just go on NIPT, but we tell them that it is restricted mainly to Aneuploidies. It doesn't test, although some of the NIPTs now give all sorts of microdeletions and so on, and that the sensitivity and specificity and predictive value is not that high. But that is the limitation. Now, if they have done PGT-A, then it becomes interesting because they have been told that it is very accurate and they have paid for it, and that cost is a big issue. Then suddenly they are told that, well, this is PGT-A, so we cannot exclude mosaicism, we cannot exclude structural rearrangements and so on. And they said, look, would you like to have another test? This is an additional cost. And besides that, there is a risk of the procedure. Guess what? A lot of them who have had multiple miscarriages, who have lost many pregnancies, and who have paid a lot for this, majority of them in my practice, at least 80% of them will refuse further genetic testing. I think this is the reality. It's good to talk theory, but in practice, if you are the parent, would you like to take a 0.5% risk of an amnio, and then you land up with a normal result and then have a miscarriage? How would you feel after 15 years of marriage? You'd be devastated. So here in a multicultural center like Malaysia, we have Malay, Chinese, and Indians. If you talk to the Malays, this is an act of God. They don't even want NIPT. No matter what, they will accept it, like the original Christians. Then you have the Chinese. They want all tests done yesterday, and they want the results tomorrow. Even if it's a cleft palate and cleft lip with a normal chromosome, they may want a termination, which is illegal in our country. So practice is very different and is very sensitive, depending on the population and the race and the religion, which I think has not been emphasized here. Here we are talking theory. Yes, but how do you put the theory into practice? We will tell them the limitations. We will offer them the tests. And even the tests are not 100%. For structural defect, you may have to do a karyotype as well. So the cost goes up to the individual. This is not government funded at all. So in my situation, I would offer them, I will also tell them the risk, but if there is a structural defect, then there is a very strong reason for me to do either a CBS or an amnio. So I'm sorry, I'm just trying to point out my reality of practice in a multicultural situation. Maybe pass on to Dr. Chang. He's got his views.
Thank you. Thank you. Thank you very much. According to my viewpoint is I'm a IVF doctor. My pregnant patients different from the others. They conceive through IVF procedure with my help. So their pregnancy is not naturally happened. So I help them to get baby, but I want to guarantee the baby is healthy and normal. So I will suggest the most accurate test. So I send them to NIPT. But if the patient insists on NIPT, I will suggest a level 2 ultrasound scanning at 22 or 24 weeks to make sure the outlook, the structure, everything looks fine for the baby. So I also explain detail. The NIPT maybe can focus on 13, 18, 21, XY, these 5 chromosomes, but the rest of the chromosomes maybe not so accurate. And with some balanced translocation, this kind of situation maybe can't detect. So if the patient know the risk and still want to choose NIPT, I will help them to finish their test. This is my theory. Thank you.
Thank you, Dr. Raman and Dr. Chang. I think due to time limitation, we are going to proceed to the session 2.
Thank you.
Thank you.
Thank you.